Now for fractures. The pathophysiology is simple. A fracture is just fancy words for a broken bone, and there are a few different types. For a closed fracture, this does not break the skin. So with this fracture, the skin is still intact. Now for an open fracture, also called a compound fracture, the skin surface is broken and bones protrude through, placing the client at high risk for infection, like osteomyelitis, the bone infection, which we cover a little later in this video. Now the other types of fractures, we have a complete fracture, where the bone is broken all the way through. An incomplete fracture, also called a green stick, only goes partially through the bone. And a spiral fracture, write this one down. This one results from a twisting motion, so it's common in child abuse. These are typically reported to the authorities for further investigation. Next is an oblique fracture, a fracture at an angle, and then a compression fracture known as an impact fracture, where bones are compressed like after a high fall or even a jump. And lastly, we have a crushing or compression fracture, where bones get crushed under a heavy object, like dropping a safe on your leg. This one places the client at high risk for a deadly fat embolism, which we also cover later. Now, you don't need to memorize every single one here. I would focus on the 3 that are highlighted. A spiral fracture indicates child abuse in pediatrics. A crushing or compression fracture here, think deadly fat embolism. And an open fracture or compound leads to more infection because the skin is broken. So Saunders mentions, the nurse is assessing a client with an open leg fracture. The nurse should inquire about the last time the client had which done. A tetanus vaccine, yes, because any type of open fracture leads to more infection. Now for causes and risks of fractures, write this one down. Bed rest, as well as osteoporosis, where the bones become very weak and porous with porosis. A big one here is steroids ending in zone, huge NCLEX tip, like prednisone. Just think that the zones make the bones so weak. And lastly is a trauma like falling off a bike. So Hesse mentions, a nurse is caring for a patient on bed rest. Which long-term effect of bed rest on the musculoskeletal system would concern the nurse the most? So bone fractures, as well as loss of muscle tone and atrophy from the lack of motion. Now the signs and symptoms are pretty simple here with any type of fracture. We'll see a lot of pain, swelling, as well as bruising, and crepitus, which is a grinding sound as the bones or cartilage rub together, and muscle spasms. Now a priority finding and a big NCLEX tip here is internal bleeding. So hypotension, tachycardia, and even hematuria, that blood inside the urine. So Hesse mentions a pelvic fracture, which is the most serious physical assessment finding for the nurse to report. Hypotension, tachycardia, and hematuria. Now switching gears here for some NCLEX priority findings on who to see first. So write down these key terms here. For a basilarity skull fracture, we see CSF, that cerebrospinal fluid, draining from the nose. This is called rhinorrhea. So key terms, clear liquid drainage from the nose area. This is a priority patient. Now for a spinal fracture that is T6 or higher, we want to make sure to monitor for neurogenic shock. Look for hypotension with any type of shock, as well as bradycardia. Write that one down. Because typical for shock, we'll see tachycardia, but not for neurogenic shock. Bradycardia is the biggest indication for a spinal fracture, as well as skin that is pink and dry. Now for a mandibular fracture, or basically a fracture to the mandible area, we'll see bleeding and drooling in the mouth, so we suction the mouth and the oropharynx. This is done to protect the airway here. Now for hip fractures, big NCLEX tips here. Key signs are shortening of the leg on the affected side, caused by the muscle spasms around the affected area. And we'll see ecchymosis on the thigh and hip, as well as groin and hip pain with weight bearing. Now, speaking of hip fractures, there's a lot of exam questions on how to treat a hip fracture. A big one is the Buck's traction, so pay attention here. This is used short-term before surgery to realign bones in the hip and femur fractures, where the bones are displaced and we typically see one leg shorter than the other. So this traction pulls back into place the bone that's displaced. We put tape directly onto the skin, or we use a pre-made boot to place on the leg, and we use free-hanging weights with pulleys and wheels to just pull that bone back into place and stop the muscle spasms. So the key points to write down, and trust me, they love to come up on Select All That Apply questions. Number one is the weights. Key terms, they should be free hanging at all times to maintain traction. Next is traction ropes. These must be tight to keep traction. So key terms here, not loose, not resting on the bed or the floor. This does not keep traction here. And when we're repositioning the patient, we hold the weights. So yes, it's okay to hold the weight while the patient repositions in bed, and it's okay to loosen the straps when the patient reports it's too tight. Just make sure to keep the traction after as much as possible. Next is keeping the limb in neutral position. And we always assess for skin breakdown. Huge risk for skin breakdown with the Bucks traction. Next is frequent neuro checks on the limb using PMSC. Pulses, motor, sensation, and cap refill. And lastly is supine position, always flat. Huge NCLEX tip here. Do not elevate the head of the bed over 25 degrees here. So no semi-Fowlers and no high Fowlers. Huge NCLEX tip. So Kaplan mentions, the nurse provides care for the client in Bucks traction, which is the most important nursing action to maintain effective traction. Allow the weights to hang freely at all times. And Saunders has a lot to say. Skin traction. The nurse should monitor which priority finding in this client. Signs of skin breakdown. And a client has Bucks extension traction applied to the right leg. Which intervention should the nurse plan to prevent complications of this device? Traction ropes rest against the footboard. No, they should always be tight here. And lastly, a client in traction, the nurse should include which action in the plan. Check weights to ensure they are off the floor. Yes, always tight straps, and weights should be free hanging off the floor. Now for post-operative care, after the client gets surgery on the hip or femur. Keywords to know here for a hip and femur surgery is a total hip replacement, obviously for the hip, and an ORIF, an open reduction internal fixation. Big long word here. This just means that pins and plates and screws are used internally for an internal fixation. And an external fixation just means that the pins and screws are used externally or outside. This is more common with femur fractures. Now the key point here is the priority or first assessments. So don't let the NCLEX trick you here. Always prioritize the order of bleeding first, infection second, and then third, position education. It's not enough to know the interventions. You must know the priority order here. So starting with bleeding, big NCLEX tips to write down. Any hemoglobin less than 7, send your patient to heaven. We must report this to the HCP. You see, the NCLEX always tests on safety first, or basically what kills the patient first. Loss of life and then loss of limb here. So monitor pulses distal to the injury and look for hypotension and tachycardia. So Kaplan mentions, a nurse is caring for a client who is post-operative total hip arthroplasty. Which of the following laboratory values should the nurse report to the provider? A hemoglobin of 8. So remember, anything that is close to 7 sends your patient to heaven. And Saunders mentions a fractured femur and pelvis. The nurse should plan to carefully monitor the client for which signs and symptoms? Tachycardia and hypotension. Yes, this could indicate internal bleeding. Number 2 is infection. We always look for elevated WBCs. Huge NCLEX tip. So write it down. Normally between 5,000 to 10,000. So WBC level of 17,000 after a total hip or joint replacement, oh my gosh, we must notify the HCP immediately, since this could mean that the patient is going into sepsis and then into shock. So we always assess the drainage of the surgical site. Look for color, amount, and odor. And if the client has pins, Then we assess the pins for that same thing and also look at the suction of a wound device if used. And lastly, speaking of pins, we always perform pin care with a sterile solution at least 3 times per day. So Hesse mentions, which interventions will the nurse include in post-operative nursing care for a patient who's undergone a hip fracture repair? Wound assessment with special attention to pain and to the color, amount, and odor of the exudate. And Saunders mentions skeletal traction when evaluating the pin sites. The nurse would be most concerned with which finding? Thick and yellow drainage from the pin sites. Yes, this indicates an infection. Now, number 3 is position education. This is always huge, especially for total hip arthroplasties. Big NCLEX tip. We always make sure to abduct the legs. Write that one down. Place a pillow between the legs. This was mentioned by Kaplan and multiple different question banks. So we always keep the legs open, wide open, never together or adducted. So don't let the NCLEX trick you. Always abducted, away from each other. And no crossing legs, big NCLEX tip again, no leaning forward, not even to tie shoes, and no sitting in a chair that is a 90-degree angle. All of these things can push the hip out of the socket, destroying the surgical site. So Saunders mentions, after internal fixation of a fractured right hip, which method to reposition the client? A pillow to keep the right leg abducted during turning. Yes, abducted, away from each other. And Kaplan mentions, total hip arthroplasty. Following surgery, it is most important to place the patient in which position? Abducted with toes pointing upward. Again, that key term, abducted, after a hip replacement. And Hesse mentions, a nurse is supervising a UAP who is caring for a patient 5 days after key term again, left total hip replacement. The nurse would intervene immediately if observing the UAP performing which action? Instructing the patient to lean forward. That's a huge key term, to put on shoes. No leaning forward, no crossing legs, and no adding those legs together. Always keep them apart. And the nurse is providing care for an elderly patient who has an internal fixation device after surgery for a hip fracture. Which intervention should the nurse implement while providing care for this patient? Select all that apply. So we turn the patient every 2 hours. We provide assistive devices for walking, such as a walker. Instruct the patient not to cross the legs, and elevate the head of the bed to 45 degrees. Yes, all these things are included for hip fractures. And Saunders mentions, after surgery to repair a fractured left-sided hip, which actions should the nurse teach the client to avoid? Crossing legs at the ankle. Yes, we do not cross legs, we don't lean forward, and we don't put the legs together with a hip fracture. Okay, hopefully you got the point now. Now, switching gears to the complications. The big one here is a fat embolism syndrome. Now, this is a major complication with long bone injuries, like that of a femur, or even pelvic and hip fractures, and even crushing injuries, where bones are crushed under a heavy object, releasing fat globules into the bloodstream, kind of like a party popper. Just like a blood clot, this fat emboli could cause deadly blockage in the brain, heart, or even lungs. So the key signs to write down and know for your exams. Mental status change is one of the first signs, big NCLEX tip. The 2 most earliest critical signs to write down for mental status change is number 1, confusion and restlessness, as well as number 2, altered mental status. These 2 came up most on the majority of question banks. Next is dyspnea and chest pain, as well as low pulse ox and even petechiae. Big key term right there to write down. So petechiae over the neck and chest, which petechiae are those little tiny red dots indicating a lack of oxygen. So Kaplan mentions, an older adult client is diagnosed with a fractured femur. The nurse recognizes which observation is an early sign of a fat embolism. Altered mental status. So you see how that key term came up in Kaplan. And Saunders mentions, the most favorable indication of a resolution of a fat embolism is a clear mentation, or basically clear mental status. Now the big intervention is to minimize movement of the fracture. This is the most important intervention with any new emboli risk here. Always stop the movement to prevent the emboli from moving around. This is the #1 most tested intervention here, so don't let the NCLEX trick you. We do not give prophylactic blood thinners for a fat embolism, and we do not use a compression device like SCDs. Now, another complication is osteomyelitis, or a bone infection, caused by bacteria that enters the blood during a bone fracture, typically with open fracture when the bone comes in contact with bacteria or even after surgery. But this can also happen through the bloodstream via a puncture wound, like a dog bite, or even contamination via needles, like with a bone marrow aspiration. So clients will present with a high fever, pain, and even pus and yellow drainage from the puncture site. So Hesse mentions, a nurse is preparing to care for a patient diagnosed with osteomyelitis. The nurse expects administration of which type of medication? Antibacterial. And Kaplan mentions, several days following a bone marrow aspiration, the nurse notes the client has a temperature of 103, and there's yellow drainage from the aspiration site. Which interpretation by the nurse is most accurate? The client has developed osteomyelitis. Now, treatment for osteomyelitis includes long-term IV antibiotics for weeks or months. Clients will go home on a PICC line, and a nurse will go visit and give these IV antibiotics in their home. Now, if the infection is really bad, then surgical debridement can be used to drain any abscesses or to remove necrotic dead bone tissue. And lastly, amputation may be done if not responsive to therapy. Now, the next big topic here is cast care complications. Now, these are the most tested. So just think about the patho here. You have a broken extremity that's big and swollen, and now we're going to wrap a hard cast around it. Well, that's very dangerous. So the key terms are hotspots, which indicate infection, and compartment syndrome, indicating decreased perfusion from uncontrolled swelling. That cuts off all blood supply and oxygen, resulting in a loss of limb. That's no good. The NCLEX will typically give you a few patients, asking you to prioritize which one is worse. So on the NCLEX, always think loss of life, then loss of limb. Don't lose the limb here. So compartment syndrome comes first. So the key signs to look for is severe pain. Now this is the earliest sign of sudden compartment syndrome. Now the top 2 P's on the NCLEX, write it down, is pain and paresthesia, that numbness and tingling. Again, these are the top 2 most tested here for cast care. They are the earliest signs that you're going to lose the limb. So for pain, write it down, unrelieved with morphine. That's the biggest NCLEX tip here. Other keywords are not resolving with medication, and even extreme pain with passive movement. All of these indicate muscle ischemia, or basically no oxygen. The limb is in essence suffocating to death. Next is paresthesia. The key terms to write down is tingling, burning, and numbness. Again, a big NCLEX tip, especially in the first 24 to 48 hours. Often described as problems moving or extending fingers or toes with great difficulty. This is an early sign of compartment syndrome, indicating ischemic injury on the nerves. So Kaplan mentions, a nurse is assessing a client for compartment syndrome who has a short leg cast. Which would the nurse identify as the finding of this condition? Pain that increases with passive movement. And Saunders mentions, suspected impairment of the client's casted extremity if which findings are noted. Select all that apply. The client reports of severe, deep, unrelenting pain. Yes. The client reports pain as the nurse assesses finger movement. And lastly, the client reports numbness and tingling sensation in the fingers. Yes, pain and paresthesia here. Now the big interventions, we must notify the HCP immediately to save the limb. They will loosen the cast to restore the circulation, to bring more oxygen to the fingers and toes, or they can do a fasciotomy to cut through tissue to relieve pressure. Now, nursing care is a big focus on the NCLEX, so write this down. Assess the fingers and toes with neuro checks. This includes PMSC very frequently. So P is for pulses. They should be strong and bounding, not pulse-less. This is not good. M is for movement with strong grips, and passive motion without extreme pain for movement. S is for sensation. There should be no tingling or no numbness. C is for capillary refill and color. Not over 3 seconds. Cap refill should be less than 3 seconds, and not pale or pallor. And the temperature should not be cold or cool. So Kaplan mentions postoperative open reduction internal fixation of the right ankle. Assessment findings the nurse should report to the provider. Extremity cool upon palpitation. And Saunders mentions a plaster cast placed on the lower extremity. Which instructions should be given to the client? Notify the HCP immediately for numbness or swelling, or if the foot becomes cool and pale. And the second question, to assess for signs of compartment syndrome, the nurse should perform which action? Assess capillary refill, temperature, color, and the amount of pain. Okay, now what about the other 6 P's of cast care? Let's play a little segment from our PVD video here. So what about the 6 P's? You guys remember those 6 P's the instructor always talks about? Well guys, the 6 P's just assess the oxygenation of the limb. Usually always the lower limb, since it's harder for oxygen to get from the heart all the way down to the legs, right? Especially with the narrowing of the blood vessels from atherosclerosis, that plaque buildup like seen here. The lower the oxygen in the extremity, the worse the 6 P's get. It's like your limb is being strangled to death, because this is exactly what happens when the body has no oxygen. It dies, also called necrosis. So write this down. The 2 most important P's that will be on your test and usually always comes up in prioritization questions. Number 1 is pain, but guys, not any kind of pain. Unrelieved pain at rest. Big key word right there. When claudication is unrelieved at rest, this means PAD has moved into the most severe stages. And number 2 is paresthesia. Fancy words for tingling and numbness. It's like when your leg falls asleep, but guys, this is way more severe version. It's like the leg is holding its breath for a long, long time, or just being choked out. All right, guys, a little side note for your future exams. These 2 P's are always the priority and will always show up on cast care and even PAD. Guys, in both cases, we have an oxygenation problem leading to a loss of limb problem. So guys, we always think of the worst case scenarios here, which always revolve around oxygen problems. Really, any oxygen problem is an emergency problem and is always a priority. Guys, that's why the ABCs are always to prevent the loss of life. Airway, breathing, circulation. They always should be assessed first. Then loss of limb, then it goes into like risk factors and other stuff. Now the other 4 P's, we sort of expect to be there, so we don't really focus on in terms of priority for tests. So we already know pulses are going to be diminished or weak, especially in PAD. And pallor is just the paleness from that low blood flow. We use the word polar, which the leg gets cold like a polar bear, since the leg lacks that warm blood flow. And lastly, paralysis, the inability to move the limb, like a paralyzed patient. Just think the limb is passed out from that lack of oxygen. Okay, now for hot spots, remember this is infection under the cast. The key terms is hot areas or a hot feeling, and even foul odors. We must report this to the HCP. So write that down. Huge NCLEX tip. Now the interventions for hotspots include assessing circulation in the extremity and change the position. So Kaplan mentions 3 hours after arriving to the orthopedic unit, a client reports a hot feeling under the cast. Which action does the nurse take first? Assess the circulation of the casted extremity and change the client's position. And Saunders mentions, the nurse is assessing the cast extremity of a client. Which sign is indicative of infection? The presence of a hot spot on the cast. Okay, now that we covered the highly tested complications of cast care, let's just talk about general cast care. We use the acronym CAST, C-A-S-T. C is for clean and dry, never wet, especially with a plaster cast. Key terms, is to cover the cast with a plastic bag for bathing. Huge NCLEX tip. Once again, especially for plaster casts. These typically take a long time to dry and will fall apart if wet. A is for above the heart for the first 48 hours. This is done to decrease the swelling and prevent compartment syndrome. So key terms, elevate the extremity. Huge NCLEX tip. S is for scratching an itch. We always use a hair dryer on the cool setting. Never put anything under a cast to scratch an itch. So big NCLEX tip again, write it down. We always use a hair dryer on the cool setting for any type of itch. Lastly, T is for take it easy. So take it easy, man, especially when the cast is initially put on. So no bearing weight on plaster casts, especially in the first few hours. This can misshapen the cast. And no finger indentation or pressure on the cast when it's initially put on, as well as no hard surfaces. Again, this can distort the shape of the cast and cut off circulation. So Kaplan mentions a newly applied plaster cast to the lower extremity. The nurse takes which action? Elevates the legs on pillows and leaves the cast open to air. And Saunders mentions which cast care instructions for a plaster cast applied to the right forearm. Select all that apply. Keep the cast clean and dry. Allow the cast 24 to 72 hours to dry, and keep the cast and extremity elevated. Yes. Next is itching under the cast. The client's statement indicates an understanding of appropriate measures. I can use a hair dryer on the low setting and allow the cool air to blow into the cast. Yes, never put anything under the cast to scratch an itch. And the third question, the nurse teaches a client who is going to have a plaster cast. Which statement by the client indicates a need for further teaching? I can bear weight on the cast in about 1/2 hour. No bearing weight when it's initially put on. And lastly, after the application of a plaster cast, which statement indicates that the client understands proper care of the cast? I need to avoid getting the cast wet. Yes, always keep it clean and dry. Okay, next we have crutch and cane training. Always a huge focus on the NCLEX and most nursing exams. So let's start with safe crutch use. Number 1, write this one down. Weight should be on the hands and the arms. Big NCLEX tip. Not on the armpits. This could lead to a big injury to the brachial plexus nerves in the armpit region. So you must assess hand and arm strength always first during crutch training. This is done to prevent injury to the nerve there. Now don't let the NCLEX trick you. We assess the hand and arm strength, not the rotation of the shoulder here. Now, it's always best to teach clients, do not use someone else's crutches. Write that down. Since the prescribed crutches are perfectly fitted to be under the armpit about 1 to 2 inches to prevent injury. And using someone else's crutches may be too tall, causing injury to the nerves there. So Saunders mentions, a client asks why the crutches cannot rest under the armpit. The nurse responds knowing which would be the most likely result. Injury to the brachial plexus nerves. Now, number 2 is gait training. So write this down. Step 1, both crutches move forward with the injured leg. And step 2, move the unaffected leg forward, or basically the strong leg after. So Saunders mentions use of crutches, which would indicate that the client understands how to perform this type of gait. The client moves both crutches forward along with the affected leg, or that injured leg, and then moves the unaffected leg forward, or basically the strong leg last. Now a little side note here. There are 3 types of gaits. We have a 2-point gait, a 3-point gait, and a 4-point gait. Which is the most advanced gait? So a big NCLEX tip. A 4-point gait, write this down, most closely resembles normal walking. So it's typically used for clients with leg weakness who can bear weight on both legs. And number 3 is the stairs. Big NCLEX tip here. So write it down. Nearly 70% of students get this wrong. The memory trick we use is up with the good leg when you're going upstairs and down with the bad leg when you're going downstairs. So Kaplan mentions crutches while climbing stairs, the correct sequence. Number 1, place the body weight on the crutches. Number 2 is advance the unaffected leg, the good leg, onto the stairs. Remember, up with the good first. Number 3, shift the weight from the crutches to the unaffected leg, the good leg. Then, using the good leg, number 4, bring the crutches and the affected leg, the bad leg, up to the stair. And Saunders mentions going down the stairs with crutches. How should the nurse demonstrate this technique? So remember, down with the bad here. Crutches and the affected leg down, so the bad leg, followed by the good leg, or the unaffected leg. Now switching gears to the cane, so the correct use, write this down. Number 1 is the strong side holds the cane, and number 2, we move the cane first and the weaker leg second. So just think of the double C's here. The cane comes first and the weak leg goes last. Now, all the time, there should be 2 points of support on the floor. For example, both feet or 1 foot and the cane. So for stairs with the cane, huge NCLEX tip here. Now, this is a big focus. Over 75% of students got this wrong. So once again, the memory trick we use is up with the good leg and down with the bad leg. So when going upstairs, you go up with the good leg. So number 1 is up with the strong leg. Step up first. Number 2 is the cane moves next while bearing weight on the strong leg. And number 3, move the weaker leg last, or last. Now downstairs, we number 1, descend with the cane. Number 2, the weaker leg down. Remember, down with the bad leg. And third, the strong leg comes last when we're going downstairs. So just remember, down with the bad when you're going downstairs. Now for a top missed NCLEX question. A client with a right total knee replacement, correct teaching. So once again, if we're talking about stairs, up with the good leg and down with the bad leg. And we always keep that cane on the stronger side. So option 1, full weight on the right leg when going upstairs. No, remember, up with the good first. So this question states the right total knee replacement. So if we're going upstairs, we have to go with the left. Now option 2, descend with the cane first. That sounds pretty good. Strong leg second, and the weak leg last when going downstairs. No. Down with the bad. So descend with the cane, that was good. But then the weaker leg, the right leg, should go next, and then the strong leg last. Now option 3, when going upstairs, lead with the left first. So in this question, yes, the left is the stronger leg. Follow next with the cane, and move the right leg after. Yes, up with the good, cane second, and then weak leg last, or last. Now option 4 is incorrect. Hold the cane on the right hand while on stairs. No, the strong side should always hold the cane. All right, that wraps it up. Thank you so much for watching. Don't